All right, so welcome to the Big Bash, everyone. We're going to hopefully bash out some knowledge about some common wounds, some of which don't get a lot of coverage in guidelines and publications and can often be overlooked in that respect, which makes management clinically difficult and often controversial at times. So we're going to have a little bit of a look at that. So let's get going. Okay, so the first thing I'm going to talk about is blisters and hematomas. So a blister can be defined as separation of epidermis, usually containing clear or cloudy fluid. Now, a hematoma is a bit different, of course. It's a collection of blood outside the blood vessels which gathers in the body tissues or a cavity. How does, though, a hematoma vary from a bruise? That's often a good question. So when I was looking this up to find some information, it stated that bruising tends to be flat, so it tends to be two-dimensional, as a hematoma tends to be three-dimensional. So that's another really good way of thinking about it. And of course, it can further be defined as a defined separation of epidermis from dermis containing a collection of blood. Okay, so what do they look like? On the left, of course, we've got a blister. I'm sure everyone in the room has had a blister at some stage, bought some shoes that may not have fitted properly or whatever. Hopefully not too many of us have looked like the guy on the other side, though, where you've actually got a collection of blood which is a hematoma, more so than what's up here, which is two-dimensional and is just a bruise. Just a bruise. Okay, so what's common causes? So blisters can be caused by lots of different things: friction, certainly partial thickness burn injury, edema, diseases, fractures, allergies, bites, stings, all sorts of different things. Hematomas, probably not quite such a wide range of causes, probably a lot due to trauma, often blunt trauma, because of course the skin's not broken, so the blood collects underneath the skin, or of course post-surgery. Okay, so looking a bit more in depth at blisters. So how do we manage blisters? Unfortunately, there is no black and white answer. So the question that is often asked of people is, do I leave it there or not? And in fact, there's no defined answer to a question that is that vague. These are all the questions that when you're assessing someone with a blister, you need to be asking before you decide what the management's going to be. And this is using the Heidi framework for wound management. So the history, how did the blister form? How long has it been there? What are the other issues going on? What does the patient actually want? Don't forget to ask them. If we look at the blister, how big is it? Where is it? What colour is the fluid? How thick is that skin over the blister? How tense is it? So if you push on it, does it feel really tight or does it feel quite fluctuant? Is there any associated infection? If we have a look then at maybe some investigations, that would centre around other etiologies. So is there pain or neuropathy associated with the blister? What's the local circulation like in the area? Are there any obvious mechanical causes to this? So that you can hopefully come down before you make a decision as to what the underlying etiology of that blister is. And that's really important, because then you've got to decide, do you leave it intact? Do you take it off? And what skills are going to be required to manage the blister or the wound subsequent to that if you take it off? And what's going to be the outcome of that choice? So there are no agreed best practice principles, as I've said, so opinion varies. So depending on the actual etiology, you might either leave it intact. There is a school of thought amongst people to actually get a needle and aspirate or draw that fluid out. That is generally not recommended for a number of reasons. For a start, you're putting something sharp near your patient. So the potential is if they move, you're actually just going to cause more trauma. Maybe you'll turn it into a hematoma. So the other problem with that is, of course, you've created a small hole into a nice, moist, closed environment. So you've actually created a portal of entry for microorganisms. So either leave it alone or you actually de-roof it, which means excising that skin of the blister completely. Now, even without knowing this patient, because you can see I got this off the internet, without knowing this, to me, this looks like something I would be very hesitant to de-roof. Because if I even look at this knowing nothing else, and I see this sort of pattern here, the first thing I'd probably be thinking of is something like a welt or a bite, you know, a sting, perhaps even a marine type sting. So you've really got to think very carefully before you just go starting to carve all this up a little bit. Yeah. And often too, in a situation like this, the patient's experiencing a lot of pain. There's a lot of pain there. If I was going to deal with one, I possibly would deal with just this one, because that's obviously quite a large, tense blister, and in fact may actually be putting pressure on the underlying skin. So in fact, without knowing everything, and I'd find out some more information, I possibly would de-roof that, but leave all these other little ones alone. So you don't have to treat them all the same even. Okay, so I've talked about aspirating fluid and why we might not do that. Now, there is an argument in some cases for leaving a blister intact. You've got a closed system. It's maintaining a moist wound environment. However, there are some drawbacks. It may actually rupture in an uncontrolled manner spontaneously. Certainly, depending on where it is, it may actually cause pain itself or interfere with ADLs. I have seen where blisters have been left long enough and they don't resorb, that the fluid in that blister does gelatinise. So you may actually finish up with that situation. And of course, if the blister's very tense, it can be putting pressure on the tissues underneath. So it can actually be causing pressure there. Okay, so some suggested blister management principles. And this comes from a bit of reading and some clinical experience, because it's very difficult to find anything in the literature, I have to say. And I'm not going to necessarily read all of these out, because you can certainly read. But it just gives you some common sense approaches to what you might do. What have I got here? Anything else? I think I've talked about all of those already. Okay, so if we look at what we might do here, this one on the left here, you're probably going to leave that alone. I mean, that's almost certainly caused by a rubbing shoe or something like that. As we know, the important thing is to identify what's caused it, so you can fix the underlying problem so the shoe doesn't keep rubbing or whatever. This also looks like potentially it's come from a shoe or something like that. This is almost certainly, if you don't do something, going to spontaneously burst. So you're probably, in fact, better either taking that overlying skin off or finding someone that can, so that you can manage the underlying wound more effectively. Yeah. Remembering that in most cases, these are partial thickness wounds. So they're going to heal, they should heal fairly rapidly. If we look at these though, now this is a blister etiology where there is quite a specific generally management principle for these, because both of these are partial thickness burns. Okay? So in fact, the one on the right is actually sunburn. So they've obviously had some shorts on here, because you can see the line, and these are actually blisters from sunburn. On this leg, you can see some of them have spontaneously ruptured. So generally with partial thickness burns, that is the one etiological type where you do de-roof blisters. Okay? So it doesn't mean you will for other types, but for burns you do. However, on a hand or something like this, you may want to actually get referral to a specialist burns unit, or at least seek advice if you're not in a metropolitan area from a specialist burns unit, because of course maintaining and preserving the function of the hand is going to be really, really important. But that is the one etiology they often are burst. These are both marine stings, okay? Very, very painful usually. These, of course, as you can see, particularly on this one, but also on this one, they're much smaller. much, much smaller. So in fact, often local first aid is what's best here. And in fact, often these will resolve by themselves fairly quickly and don't really need someone to go in there and take them all off. These ones here, you need to know what the etiology is. Okay, I don't know what the etiology is. You'd have to do a lot more investigation. I mean, these, 2 little isolated blisters in otherwise normal skin, that's a little bit of an odd situation. So what do you really need to know a little bit more before you decide what's going to be the appropriate management. The same with this one, which actually I'm pretty sure was not a shoe rubbing, was actually a bite from an unknown source. All right, so you really need to find out a little bit more as well out. This is now actually the opposite generally. So these are what's called fracture blisters. So these are blisters that can occur in the skin as a result of fractures. The one on the right's around a knee, of course, the other one's around an ankle. Often they actually occur around long bone fractures from the twisting mechanism that occurs during the injury. Now, if you talk to an orthopaedic nurse, they will usually say that they leave these alone. Okay? So unless they're really, really tense and causing a problem, often these ones are left alone. Now these bottom ones here are quite interesting because these are a specific type of etiology again. So the bottom ones are actually a result of a condition called bullous pemphigoid. So bullous pemphigoid is an autoimmune condition often found in older people. It's associated with a number of other things, but it results in multiple extensive blisters of various sizes coming up over different areas of the body. They can be very, very painful, and when some go away, more will occur. So unless you control the condition, they are very, very difficult to manage. In fact, you can see on the one on the right, you can see where some of them have healed and now we've got more coming up. Okay, so this needs a diagnosis. Okay, so if you're suspicious of this, this needs a medical diagnosis, which is usually done by a tissue biopsy and aspirate. So just keep that in mind. Often, I must admit, these ones, unless they're perhaps very large, where you may consider de-roofing it, these actually often do quite well with something like a silicone tulle sheet on them, such as Silflex or Mepitel, which often gives the patient comfort and of course can be left in place so you don't have to disturb it underneath. So here's a case example of a lady I looked after a little while ago. She could not tell me how this happened. She did have paraplegia, but she could not tell me how this blister happened. Now, interestingly, I'll just tell you a little story. Interestingly, she got a locum to come in and look at this blister, but this was before I had seen it, and the locum got a torch and shone it through one side of, I kid you not, shone it through one side of the blister and said, "Oh, that fluid's cloudy, it must be infected," and he put her on antibiotics. I hope none of you think that's actually infected, because it's not. And I've never actually heard of that before, so I'm not sure where that GP got that from. She actually didn't take the antibiotics, which was probably good. But the issues for this lady here were, there was no history of fractures, there was no history of other high-risk things. So I'd have to presume that given that she has paraplegia and can't feel this, that she probably rubbed it on something. Yeah, she probably rubbed it on something. I mean, there was no evidence of other burn injury or anything like that. But I can tell you, she was not sleeping at all at night because she was so worried that she was going to roll over and that this was going to burst everywhere. Okay, of course, putting footwear on is very difficult. It's on the medial aspect, so, you know, how it rested on her foot plates, all sorts of things like that were an issue for her. So on this day, I actually did get a pair of sterile forceps and scissors, and I took the top off. So I basically, and you'll see in a minute, I just cut the skin of that blister off, soaked up all the fluid, and put a dressing on. And within 2 weeks, that was pretty much reepithelialised. okay? I just used a basic foam dressing, not one with silver or anything, just a basic foam dressing. She was much happier and the wound actually healed quite quickly. Okay, hematoma. Not very different actually to blister. It really builds on blister management. I'm actually in this presentation predominantly going to focus on lower limb hematoma. It is one of the most poorly managed injuries that people get, usually caused by blunt trauma. People either fall, scrape their leg, maybe sometimes a closed fracture or a crush injury or a bit of friction. And in the population these often happen. They're complicated, of course, because a lot of these more elderly people are on anticoagulants. So it just bleeds into the tissues. So it usually presents as a defined, protruding, dark mass. It's really important to understand how hematomas behave because it's how blood behaves. So of course, initially as it's bleeding, it's nice and soft and fluctuant. It's fluid blood. However, like any blood, it will actually clot and become firm. So within about 24 to 48 hours, that hematoma is usually solidified. Okay? At about 10 to 14 days, the body actually starts to break that clot down again. So the clot will actually start to liquefy again. It doesn't usually go back to being completely fluid. It'll go back to being a sort of a semi-solid gelatinous type situation. It looks sort of like port wine jelly. Sorry for anyone that likes port wine jelly, but that's a bit what it looks like. It's interesting because this is actually the same mechanism as secondary hemorrhage. So it's why secondary hemorrhage happens at 10 to 14 days because clot that was perhaps occluding that starts to soften and break up and then you bleed. Hopefully not any of you. All right, so here's a few hematomas. So you can see here there's been a bit of a skin tear, but then that blood has just collected under the skin. Okay, same in this situation. So this is the same one from two angles, so from the top and from the side. So you can see that really defined collection of blood there. This is a bit more extensive one. Okay, you can see where it is actually bulging there, but this is a much more extensive hematoma. Okay. Okay, so again, it's the same as we did before. Using our Heidi framework, it's exactly the same type of questions. You know, how did it occur? How long has it been there? What other medical conditions does the person have? What medications do they take? Be cautious of anticoagulants. Where is it? Is there associated infection? What's the local circulation status like? Because this is quite important. And then what are we going to do about it? Certainly for, I have to say, a very extensive hematoma like that, I would definitely be recommending medical review. However, whilst I say that, unfortunately, one of the most common things that happens when people with hematomas do seek medical advice is actually that they are sent home. Yep. And sometimes it can be other nursing advice as well. So it's not just medical advice, but when a second opinion is sought, it often is that the practitioner doesn't know what to do, so they don't do anything. So what should we do? Well, stop the bleeding, of course. So try and keep the hematoma as small as possible. So a bit of pressure, maybe some ice. Elevate the leg. Again, try and stop that bleeding. I've said about medical assessment, if it scares you or if it's very large, the other time when I think medical assessment is absolutely imperative is if it's over a joint. Okay, I have actually seen 2 hematomas that were left completely untreated for quite a long time that did finish up eroding into joints. Okay, one of which had a hip replacement underneath it. And that didn't unfortunately end well for the lady because an infection then got into this lady's hip joint and they didn't want to take the joint replacement out. So despite extensive antibiotics, she basically finished up for the rest of her life having to wear a stoma bag on her hip draining purulent fluid. And I believe that unfortunately, if the hematoma had perhaps been addressed earlier, that situation may not have occurred. The other one I saw was actually a knee joint exposed. So again, a haematoma that had not been treated and then had created a very large wound, which had just been left, unfortunately, untreated. Yeah. So if that does happen, if you're not happy or you're at all concerned, I would actually encourage a wound specialist to get involved and give an opinion, and maybe do some assessment and interventions. Certainly, you usually do need to get rid of the clot at the appropriate time, but it usually means you have to wait for those 2 weeks or more. It's not, you can't conservatively get rid of the clot when it's actually firm and hard. So that's just something to think about if you are going to be making a referral to a wound specialist, is at what point that's made, because if that clot is really hard, they won't probably be able to do too much to it at that stage. Certainly once the clot comes off, wound management and appropriate dressings, and absolutely compression if it's not contraindicated. So if they haven't got clinically significant peripheral arterial disease, then I would certainly put compression on them. So here's a case example. Again, this actually occurred in a hospital, in a public hospital here in Adelaide, and whilst this person was an inpatient, the staff in the hospital didn't know what to do with it, so again they just left it alone and discharged this lady with this out back into the community. This is what happened. I took actually took the clot off, and you cleaned it up. So that's initially, and then cleaned the wound up. And certainly my intention was to actually get this lady into some compression. You can see she's got quite a bit of edema in her lower leg. Unfortunately, I didn't get to do that because this night here, she actually died. Not from her wounds. God. She actually had really severe asthma and had like a respiratory episode and couldn't be revived. So, I mean, her husband was very grateful for the care that we'd provided out in the community, but unfortunately I haven't got what happened in the end because it sort of wasn't what was expected. Here's a really extensive haematoma in a morbidly obese lady. So this lady knocked her leg on a cupboard in her laundry and didn't do anything about it and didn't tell anyone about it for a couple of weeks. So the problem you had here, of course, was you had haematoma in a large amount of fat. Okay? So by the 16th of December, that had actually broken down to that extent. So you can, in fact, where's my pointer? You can actually see some of that haematoma still left in here. This is fat. So whilst it looks yellow, it's definitely not slough. That was actually all fat through there. She absolutely had a cellulitis by this stage and was certainly put on oral antibiotics. So on this date, what I did was, this was all soft and sloppy by this stage. It actually didn't take much to get rid of this. You certainly didn't need anything sharp. You almost scooped it out. The problem was, as you can see, it was tracking round the back, and this bit here was really heavy. So, you know, we didn't want to finish up with like a kebab type effect happening. So I did, on this day, after I'd cleaned that all up, I did put her in compression straight away. Not only, she didn't have necessarily overt venous insufficiency. She certainly didn't have arterial disease. She was only in her 50s. But you needed to support that wound. And it would help to reduce your exudate level. Mind you, that was high for a little while. By the 3rd of January, with good wound management and ongoing compression, that had reduced to that size. And as you can see now, we've actually got really good quality granulation tissue in there. Mind you, I do have to also say it wasn't just that alone. So at this particular point here, this lady actually believed these wounds were probably going to kill her. Okay, so she had agoraphobia. She hadn't left the house for 4 years. There was no way she was going to hospital, because I have to say on this day that was my plan, was get in an ambulance, go to hospital, probably needs a surgical debridement, intravenous antibiotics, a vac, and God only knows what else. But she wouldn't go, because the last couple of rallies that had gone to hospital had not come out again. Well, maybe in a box, but not come out again on their feet. So there was no way she was going. So this was entirely managed at home, this wound. But the consequence of her thinking that they were going to kill her is she changed her habits. She actually started to lose weight. So in a way, I always get really quite emotional, because it's a really good outcome. In a way, something terrible that happened to her actually had a good outcome. So she actually, some of this you're starting to see now is actually weight loss as well. So by the 14th of February, we were down to that. And by 20th of April, that was completely closed. Okay? So an excellent outcome. I have to say, her ambition was that by the end of that year, she was going to be able to buy a pair of jeans off the rack. So it was a very emotional journey. Because when I met her, of course, she was wearing tents. And in fact, when I met her, she couldn't fit into the shower in the house. So the husband used to take her outside and hose her down. So it was a really, really awful situation that actually, despite something terrible happening, had quite a heartwarming outcome. Yeah. Okay, so to finish off with the ubiquitous abscesses. Okay, so what's an abscess? An abscess is a localised collection of pus, usually caused by a bacterial infection. So this is quite interesting, and this is worth remembering, is this pyogenic membrane. So one of the things that can happen with abscesses that I'll say up front, which is often worth remembering, is they can form a capsule around an abscess. So this can impact the success of some types of management as well. Okay. So the management, though, will vary, again, on all those things we talked about before, the location, the type, the size. So obviously, the management for an abscess submandibular is going to be quite different to perhaps an ischiorectal abscess, potentially. Yeah. Okay, so skin abscesses, they're really common. They're really quite common. They may actually spontaneously drain and resolve by themselves. Certainly, people are often given antibiotics with varying degrees of success. You often do need to, at the very least, or someone needs to incise and drain them. However, I was going to say, with incision and drainage, one of the issues that happens is often that incision is not big enough. You actually need to make a decent, or the medical practitioner or yourselves, if you're a medical practitioner or you're able to do this, needs to make a decent incision for a couple of reasons. Because often you've got to let the stuff drain out, all of it. The other thing is, a lot of these abscesses happen in quite young people. And what do young people do well? Heal. So I'm sure a lot of you have seen this, where a small incision's made and within 2 or 3 days sometimes it's almost closed over again. And then you've got a problem underneath. The other issue is that some may actually require excision curettage, which is really excising any capsule that might be there. Okay, so sometimes abscesses will refill. The other thing that can happen is that capsule will actually contract and harden. So you'll finish up, the person will finish up with quite a hard lump under their skin. I have to say, from a personal experience, that's exactly what happened to my son. He finished up having to have plastic surgery. In fact, it wasn't that person's submandibular abscess, but it was very similar to that. So it came up, went off to the GP, antibiotics were given. Antibiotics didn't do a thing because it's an encapsulated area of pus. So the GP then incised it and tried to drain it. Got a little bit of stuff out of it, but not all of it. Of course, then it closed up and the capsule actually contracted and hardened, and he actually had a visible lump on his face. So in the end, unfortunately, he had to go off and have plastic surgery to excise that. And he does have a little scar there now, but I guess you could make up a good reason for having that, not I had an abscess. Yeah. So you actually want to completely drain it and allow healing from the base. So, something like this is going to need a decent incision. So it is going to need a decent incision. And oh my God, isn't the internet wonderful? If I'd really wanted to make everyone feel a bit queasy, I probably could have got a video of that. But you've really got to get it all out. Okay. Now, this is the other thing I want to talk about, is the third point here about packing abscesses. All right? So packing will not stop small incisions closing. Okay? So the body is very, very tenacious at healing, particularly younger people. So popping a bit of gauze or a gelling fibre in there is not going to stop that process happening. Okay? The only way you'd actually be able to stop that is if with something rigid to actually hold or stent it open. Okay, so just remember, packing won't necessarily stop that. Okay, so you can get, I don't know whether these are DIY instructions off the internet maybe. Put some local in at the maximum point of fluctuance, but I like this because it's basically a wide opening, not just a little puncture or a little cut. This has really opened it up and cleaned it out. Okay? Because otherwise, this is the problem that you can finish up with, is you finish up with a slit, and please, I'm not recommending that you clean these with cotton buds. It was the best diagram I could find that really illustrated what I wanted to talk about, which was that you can, of course, finish up with an incision or a hole and a much larger cavity underneath, okay, which then can be a management challenge. Okay, so post-operatively or post-procedurally, make sure you measure that wound depth regularly because you want to know that it's not just getting smaller on the top. You want to know that it's actually getting smaller on the inside as well. Certainly, if you want to, you can flush it with a bit of saline to clean it out. Generally, your surfactant or antiseptic solutions generally may be not necessary. Certainly, if you're going to use those, I'd say pretty short term. If you're still getting a lot of gungy exudate coming out of that, then I'd actually be concerned it needs more than perhaps a bit of povidone iodine or something like that in there. Yeah. Packing might be required initially, and I'll talk a bit more about that, and usually a simple secondary dressing will suffice. So a pad type dressing, maybe if it's in an area where it's going to get contaminated or soiled, maybe an adhesive foam dressing or something like that. Okay, so packing these wounds post-operatively, only pack them lightly. It's not the Guinness Book of Records. You don't want to stuff as much as you can in, so you're aiming to loosely fill any dead space. You absolutely need to make sure that that packing material is not going to break up or disintegrate, particularly if you have a larger cavity under a smaller hole, all right? Because all packing materials I won't say all, but pretty much all packing materials that are used in general clinical practice are not reabsorbed by the body. They are going to form a foreign body there, all right? So there have been numerous unfortunate incidents of people with good intentions packing these types of wounds where material has actually broken up and been left inside and then caused a problem. Certainly can set off a nasty infection as well. The other issue is the packing material must still allow the exudate to drain. You don't want to be forming a plug, all right? So there's not a lot of packing materials that do actually actively wick fluid out, all right? So sometimes packing will actually just plug that hole up, and the exudate then, and maybe any purulent exudate, is just going to be kept in that wound. It also shouldn't be adherent to the wound bed if possible, because that's just going to cause pain and trauma. And certainly, if you cannot entirely visualise that wound base, every instance of packing removal and insertion needs to be specifically documented as a risk management strategy. Yes?
What's the actual reason
It's a very good question. You are aiming to loosely fill dead space so that the wound heals from the bottom up. Now, essentially what you're trying to do with packing is actually stop it closing halfway, okay? So that you actually get a collection underneath. Yep, that's really what packing is designed to do, is so that you don't get a collection underneath. And you get more or less an even healing. However, it's a very good question, because in clinical practice, we do often still tend to pack too many wounds, and we tend to pack them far too tightly. Okay? You've always got to think of what that packing is actually doing. I've seen lots of instances of wound healing being retarded because people are putting too much packing in. Yeah. I mean, all packing materials are foreign body. You know, it is all a foreign body. Now, it's all designed to be used on wounds, but it always can cause problems as well. So you always have to weigh up the advantages and the disadvantages of what you're doing with your packing. So it's a very good question. Yeah.
Sue,
Yes?
an alginate dressing, the alginate with then not really recommended?
Absolutely, unless you can entirely visualise the base. Because the issue with alginates is alginates do break up when they get wet. Yep. So if you can't entirely see that wound base, there's no way you can be sure that you've entirely got that out. Yeah. Yep. Yep. Talking about packing some more, cease that packing once it's progressing and the cavity is reduced in size. All right. I've talked about that. If it's not getting better over a reasonable time frame, and I would say with most of these I'd be looking at about 4 weeks, if it's not significantly smaller in 4 weeks, reassess things, get a second clinical opinion, because again, most of these should heal quickly and easily. You know, these should not be turning into chronic wounds generally. Probably the only exception to that is some of the chronic ischiorectal abscesses that form. That would possibly be the one exception, but certainly abscesses on other parts of the body should get better quickly. Yeah, yeah. Okay, a specific type of abscess is a pilonidal sinus. I hope most people have heard of a pilonidal sinus. I hope most of you have never had one. Although you may know someone that has had one, they're actually quite common. But because they predominantly occur in young people, it's not as though they stand around, you know, at the pub talking about their pilonidal sinuses. Maybe they do, I don't know. But yeah, I'm sure it's not a topic of bar conversation. It was first described in the early 1800s, but I'm sure occurred long before then. And the term comes from the Latin meaning a nest of hairs. Sounds wonderful, doesn't it? It's quite characteristic, and it's found within or just above the natal cleft. Now, it can also happen on hands, it can happen in feet, predominantly in people that cut hair, hairdressers and barbers. Okay, so they can get a very similar type of process that happens from hair actually getting into their skin from their clients. Yeah. So it's mainly a young person's disease. Even this, I've read a couple of different things. So where I read this was puberty to 40. I have actually heard a surgeon say that generally if you haven't had one by the age of 25, you're very unlikely to get one. And they are predominantly a teenager's disease, a teenager's problem, to be honest. Incidence is about 7 per 10,000. Affects males 10 times more than females, but it certainly can affect females as well. It's not just males. It's predominant in people with white skin, us Caucasians, and it's got other names. So pilonidal abscess, I actually think in most cases that's actually a better description of what it is. Pilonidal cyst, or if you really want a fancy one, sacrococcygeal pilonidal disease. Okay, so there's 3 different types of this. There's acute, chronic, and complex or recurrent. What are the risk factors for getting this? A sedentary occupation or lifestyle, a family history, which is interesting, and we'll come to that, being overweight, and local irritation or trauma. So it's interesting to know that during World War II it was actually known as Jeep disease due to its prevalence in Jeep drivers, which didn't have the suspension that they have these days. Because as these buttocks bounced over things and rubbed together, then it actually forced hairs into the skin in that area. Okay? So this is quite an interesting statistic that I came across, that between 1941 and 1945, 80,000 US soldiers were admitted and treated in army hospitals for this. So an average length of stay of 55 days for that. So huge impact this had during the war. Luckily, Jeeps and cars generally have improved suspension now, I think. All right. So what happens? What happens? And we'll talk a little bit more about this, but a hair, and I'm not going to accuse any particular hairs at this point, but a hair burrows into the skin and then it sets up an infection. It sets up a local infection because it takes bacteria with it, sets up a local infection and causes an abscess. And this is what is often seen. So it's an acute abscess around the natal cleft, often excruciatingly painful. And in fact, it is usually the pain that drives people to seek treatment. Because as you can imagine, a 15-year-old boy is not going to seek treatment for something on their butt unless they absolutely have to. So these are often left quite late. They're not something that's often found early. So why does this exactly happen? Now, lots of people think that they're ingrown hairs. That's actually not the most common reason. They're usually distant hairs, in fact. Yep, okay. So the exact cause is uncertain. There are actually about 3 or 4 different theories, and they're probably, like most of these theories, a bit of a combination of things. And some might be more predominant in one person than the other person. So one of the theories is that it's to do with the shape of the sacrococcygeal curve there, okay, which explains possibly why there's a genetic predisposition, because that would be genetic. So if where your sacrococcygeal curve is a bit more bowl-shaped, it tends to collect hairs that fall down. So hairs off your head that fall down, a bit of debris, those sorts of things actually tend to collect there. Yep. And then forces such as repeated bouncing, slumping, riding in a Jeep, they just actually drive the hairs in and make that worse. Okay, the other one, there's a theory that pilonidal sinuses are commonly associated with pits in the midline natal cleft, which are a bit like wide pores or wide hair follicles, but that's not necessarily what they are. And again, these pits actually are a repository where hair can actually get in and burrow into the skin. Again, hair can be local or distant, and I'll show you a couple of photos in a minute, but interestingly, hair itself is actually not found in all cases when they open them up. Yeah. So, of course, again, similar thing, gets into the pit, then it becomes swollen, closes it in there, and it becomes infected. Now, in most cases, pilonidal sinus is actually an abscess, so it's often closed. It gets its name because sometimes that chronic abscess will form a tract to the surface which drains, which is where the sinus comes from. Yeah, but they certainly don't all drain. Okay, another theory is that it's only loose hair that can insert. Okay, so it rules out our ingrown hair theory. Interestingly, there are 3 factors, some of which are repeated from previously. Straight hair is more likely to insert than curly hair. And luckily I'm well over 25, well over 40 now too. And that if you've got scaly hair with a chisel type root end, that's more likely to insert, which makes sense because that's going to be, a bit more pointy. Then you need some force, which causes the hair to insert, and you need some sort of vulnerability in the skin. And once one hair goes in, others take up the lead and they follow. Okay? This possibly, though, explains with our previous theory why hair isn't always found, is because, in fact, if someone does form a sinus, it may actually eject those hairs from that sinus. even though it's set up a problem that needs to then be addressed. Okay, another theory. So sex hormones affect the pilosebaceous glands. Oh, what a fantastic word that is. I'm sure there's not enough instances where you could throw that into conversation. The hair follicles actually become distended with keratin and then leads to folliculitis. So this is more a local type theory. And then that follicle ruptures and sets up an abscess as well, which again might lead to a sinus tract. So as you can see, there's a number of different theories about how it might happen. Okay, I think I've talked about this, maybe asymptomatic, usually an abscess, maybe actually multiple abscesses, and I have unfortunately seen that in someone, maybe obscured by other things, and then some people get this complex or recurrent disease. So there are some people who may have even had surgery and actually develop another one. And in fact, I've met a couple of people who are on about their third or fourth polynidal sinus, unfortunately. Yeah. All right, the vast majority of cases require urgent surgical intervention. This is a bit more, to be honest, than an incision and drainage in a local general practice. They usually do need surgery, yeah. And certainly conservative management is usually futile. They're well, usually, as I said before, by the time they present, they're well past that. There's also some stats from incision and drainage which show that if you do a simple incision and drainage, about 50% will require further surgery and recur. There's a much higher recurrence rate. So if someone incises or excises and curatages that abscess completely out, generally 90% of those are going to be healed in a fairly short space of time. And certainly leaving it open to heal by secondary intention has a much better outcome than direct closure at time of operation. Yeah. All right, so you've got polynidal sinus here. So rather than just incising and draining the skin, the surgeon needs to go in and actually excise the whole thing, really, which does mean for some people they can be left with significant wounds. And that's what they might find. So as you can see, they're not all short and curlies. As you can see, there's actually, in both of these pictures, there's actually some quite long hairs there, okay? So, you know, it's not just the local hairs that may cause this problem, yeah. However, I think that doesn't help. And possibly having a lot of local hair there does help to trap other hairs and encourage them to get in. Okay, so usually needs a general anaesthesia. The vast majority, though, will heal in 8 to 10 weeks with a low recurrence rate. So that's heartening to know. Yeah. So excise the whole thing down to good, healthy margins, but you are often left with a large wound afterwards. You know, you're often left with a large wound. Oh, look, there's some more pus. Yeah, but a significant wound. So the majority will heal. Some of them that are larger or more complex may have more advanced therapies like negative pressure therapy. That can often be quite challenging in that spot, as you can imagine. Sometimes used for quite large ones or for people who have had recurrent polynidal sinuses as well, or where they've been a bit difficult to heal. Yeah. Okay. So I think I've talked about the first one. Excision and reconstruction, certainly direct closure is normally not done. Sometimes if there has been chronic recurrent disease, a plastic surgeon might actually do a flap procedure to get this closed. The other thing that a flap procedure will do is potentially change the shape of that sacrococcygeal area to try and flatten it out so that it stops collecting hairs so readily. Okay, but again, as you can see, this is not small surgery. You know, this is reasonably major surgery to actually fix a polynidal sinus or to fix recurrent disease. Yeah. Okay, so from a clinical care point of view, these are acute surgical wounds. They bleed in surgery. So I have to say the most common thing that surgeons will do is pack them tightly. I mean, they're packing for haemostasis, which is great when you're under anaesthetic because you can't feel it. Not so great when you wake up and someone has to try and take it out. The other interesting thing is from risk management strategies is often the wound dimensions that they create in theatre are not recorded anywhere. So you don't know how big it's going to be. The other thing is the amount of packing used by theatre staff is not often precisely recorded. So it might say something like packed with calcium alginate or packed with whatever brand name they're using, but it won't tell you necessarily how many pieces they've used. So you often go in quite blind as to what you're going to find. For the first dressing change, that the patient usually requires quite strong analgesia. I would say opioid analgesia, absolutely, before that first dressing change. I would recommend removing the outer dressing and getting them to sit in water, in a bath or a shallow tub for 30 to 45 minutes to try and soak that packing. Now, you'll see that this is not something I'm going to recommend for ongoing care, just that initial visit, because as you know, often by this stage too, that blood's all hardened, so it's very solid, very, very solid. So you need to try and soften it up. The other thing that's really important is to position the patient to visualise the wound and minimise their ability to clench their buttocks. I know that sounds cruel, but the position you do not want your patient in is lying face down, prone. All right, because if you lie face down prone, it is very easy to clench those buttocks. And remember the sort of population these are occurring in. They have good buttock tone. So, with that in mind, I must admit, these are the two recommended positions. This is a bit undignified, I find. I must admit, generally, most people that I would look after with a pilonidal sinus, I would get to position like this, on their side with their knees drawn up. It's much, much harder to clench your buttocks, and you can actually, as a clinician, actually see the wound a lot better. But I'm never ceased to be amazed at the people I go, and they've already had this for a while, and they say I'm the first person that's asked them to position themselves like that. They say they've been, lying face down. Yeah. Have good lighting is the other thing. So even if you're working in a clinic or a hospital where you've got good overhead lighting, these are often very difficult wounds to visualise, and particularly if you've got someone on their side. So whether you've got a clinic lamp, someone holding a torch, or if you're in a home environment or a general practice, buy yourself a lovely little LED headlamp, because then you'll actually be able to see what you're doing. $10 at Anaconda on special, so, they're not expensive. Initially, your plain metal forceps are going to probably be best for getting that packing out. Trying to wrangle plastic forceps out of a dressing tray is going to be very frustrating for everyone, not least of all clinicians. If you're still finding it difficult, this is actually where something like a surfactant solution, like your Prontosan or Octenolone, where you might be able to put it in. Because remember, they break down, particularly your betaine in the Prontosan, breaks down protein bonds. So it will start to help to break that down. You will need to leave it there at least the 10 minutes, probably longer, 10 to 15 to 20, to actually soften that up so you can get it out. Okay. Then you've got to assess your wound and decide what you're going to do. And that will depend on the dimensions of the wound and all those other sorts of things. Certainly ongoing care, hygiene is really important. I am not a fan of sitz baths, okay? Not at all. And that would not actually be consistent generally with what we believe about treating wounds in an aseptic manner these days. However, these are probably one of the types of wounds where I do think potable tap water is fine, but under the shower. You actually want them to be leaning over in the shower and actually getting some irrigation in there to rinse that out properly. Again, remember, particularly initially, these are really painful, so it's really hard to get in there and clean them mechanically. So getting into the shower is really important for them to be able to do that. They, of course, need to be extra careful with bowel actions, that they're basically not wiping faeces into it. All right, so they need to be really careful. Often it's said, they should have a shower after every bowel action. I don't know about you, but that's not always practical. That's not always practical, but they do need to be very careful with how they wipe themselves so that they try and maintain that wound clean. The other thing I find is just sometimes that just the whole area just gets quite awful. So showering just helps to clean that skin around the wound as well. Initially, they will need regular analgesia, and particularly prior to dressing changes. But that should lessen off as the wound starts to heal. Unfortunately, it's not a time for them to be playing footy and soccer and running marathons. So they do need to avoid strenuous activity because that's just going to place increased activity on those buttocks, which is then going to potentially traumatise that healing wound. Now, if they do have quite a lot of local hair around the area, hair removal may be considered. Certainly one of the things is if there are a lot of local hairs that I have seen is although they don't drop into the wound, because they often do tend to be short and curlies, they do tend to sometimes almost grow down into the wound from the skin, and you really don't want that. But please avoid shaving, of course. I think we all know that these days. I tend to find during the healing process, I'll just get a pair of little iris scissors and trim the hairs back around the wound edge and the peri wound so that I'm keeping that free of any hair. But certainly some guys who have a problem with this, and particularly if they've had recurrent disease, will often consider laser therapy or something more permanent to take that hair off. As I said, it's not often the cause, but it may be a contributing factor. Okay, so light packing initially. I would recommend a gelling fibre or maybe a wicking type foam that is one that doesn't have a backing on it. If you've got nothing else, then ribbon gauze. Ribbon gauze, of course, certainly has some significant disadvantages, but may be appropriate in some cases. And as I said, be very careful with your packing and certainly document it. Secondary dressings are over these. You often don't need to go high tech. Often a simple absorbent pad dressing is fine. In fact, some guys quite like sanitary pads. You know, they can use them like women do. Stick them in their pants. They'll stick onto their pants. They'll absorb some fluid. They can change them pretty easily if they need to. So be inventive and keep it fairly simple. Because as these wounds heal, a lot of these patients can actually manage the wound themselves. Once you haven't got a deep cavity anymore, they can often manage these independently with maybe a clinician checking on them from time to time. Remember to keep measuring them, okay? We want to make sure that it is actually getting smaller. They do need good nutrition. As I said, most of them will heal quickly, but I have to say, you know, teenagers' diets aren't always the best. So good nutrition is really important. Excellent personal hygiene. The other thing I haven't mentioned is underwear. Underwear is really important, actually. You need to give these wounds, these areas, support. Okay, so nice, firm, supportive cotton trunks are the best. So if you remember the trunks that Daniel Craig was wearing when he came out of the ocean in Casino Royale, that style of thing. Okay, so I don't know if your patient's going to look like Daniel Craig coming out of the ocean in Casino Royale. You might be lucky. But that's the type of thing you want, is something that's going to actually give support. It's going to be cotton. It's going to actually stop those buttocks moving around too readily. All right, so that's really important. All right, complications. Recurrence, infection, inflammation, abscess and seroma, even though it was an abscess to start with. Certainly, if the size hasn't reduced by at least 30% or more in 4 weeks, review your management. Review the management of the patient. So common causes of failure to heal are infection, in particular hypergranulation. These wounds can tend to get very hypergranulated. Certainly trauma may be from overpacking or adherent packing, or again maybe their lifestyle factors. So certainly the other thing, if they're a smoker, I'd encourage them to give up smoking. Yep. If you are having trouble healing it, maybe think about backing off with the packing. If you are concerned that there is hypergranulation, then I do have some specific recommendations. Biotin AG is actually very good, and you can get it in a cavity form. That tends to be really good. One of the high salt dressings, because that will suck the excess fluid out. So something like Mesalt or Curasalt can be really good, and you can get that in a packing form. Or I have to say, I've also had really good success, this is using gauze, with your simple povidone iodine soaked gauze. So I can remember one guy that I was asked to see and had a non-healing pilonidal sinus for over 3 months, and he was very frustrated with that, understandably, by then. Predominantly a hypergranulation problem, and I actually started with the really easy stuff, povidone iodine soaked gauze, and that was healed in quickly and easily within the next 4 weeks. So, and he'd actually also had multiple courses of antibiotics which hadn't done anything systemically. You often need local treatment. Yep. So that's often an ongoing issue. So if it's expected to heal and it's not, please make sure we do something about it. Don't just keep doing the same thing over and over again and expecting that something different is going to happen. So that's what I say. Don't keep doing the same thing, because sometimes that's what we do with chronic wounds. Okay. So there's a bit of a conglomeration of pussy bits and bloody bits and all sorts of things. So I hope that's been of some use. So thank you very much, and we'll get Margie on board.